to announce for the another meeting in the International Egyptian Indian Online Orthopedic course. We have been for 11 webinars since about 3 months ago, and we are on the 12th webinar. First of all, I would like to thank my dear friend, Professor Sernives Kamphamti, for his great effort for preparing this course, and also for his effort to prepare the Indian session in the upcoming International Trauma webinar. Also, I would like to thank EVA Company for sponsoring this course, and many thanks to Ortho TV for live streaming the presentations of this webinar to all Asian countries. Now we will start our upcoming webinar now with Professor Santosh Sahanand from India. Professor Santosh will speak about implantless economic ligament reconstruction of the knee. And the second speaker will be Professor Elganainy from Mansoura University. Professor Abdel will speak about controversies in management of knee instability with varus malalignment. Our first speaker will be our dear Indian professor, Professor Santosh, and Professor Sernives will introduce him. Professor Sernives, please, sir.
Thank you very much, sir. Good evening, everybody. As always, I would like to thank Professor Elashab for his kind words, and for the Egyptian Orthopedic Association for giving these opportunities to organize, and Indian Orthopedic Association as well as Ortho TV for transmitting this. It's a pleasure to introduce Dr. Santosh Sahanand, who is, I'm not getting the first slide. There it is. Dr. Santosh Sahanand is an arthroscopy surgeon. He has been the past president of Indian Cartilage Society and medical superintendent and consultant knee surgeon at Ortho One Hospital, Coimbatore, India. He's in charge of the knee and rehab unit there, and specialized in knee multi-ligament revisions, cartilage, patellofemoral and joint preservation surgery. Apart from that, he does weekly admission days with trauma surgery, and he's involved in teaching fellows basic arthroscopic techniques. And he's currently holding the post of medical superintendent of the hospital, as well as the past president of Indian Cartilage Society, past governing member of the Indian Arthroscopy Society, executive committee member of the Indian Biologics Orthopedics Society, and Tamil Nadu Arthroscopy Society. He has had 43 publications, 108 lectures, and several workshops as faculty. And he trains about 12 surgeons every year, including 7 arthroscopy fellowships of 12-month duration. And notable activities include several live surgery demos of arthroscopy techniques, and an external expert guide for PhD students at PSG Institute. He's also done the guide for PhD students in Shastra University in Tanjavur. He's had several innovations to his name. Some of them he will be presenting today. Implantless reconstructions of the knee. He has published a few papers on these. That will be the topic of his presentation today. He's also done some more innovations like interlinked hamstring ACL with ALL reconstruction, patella fracture suture bridge fixations, prone position for arthroscopy of patella cartilage ACI, and floppy lateral position bipolar cartilage defects, push and park technique of patella micro drilling, nut and jelly technique of hybrid cartilage reconstruction, peacock feather technique of meniscus repair. Several good techniques. I would like to thank Dr. Sahanand for kindly accepting the invitation to present today. Thank you very much, Dr. Sahanand. Over to you.
Thank you very much, sir. Thank you very much for the elaborate introduction. As I share my screen for today, I thank the Egyptian Society for inviting me here. and it's a great pleasure to share our work to the international forum. Before I start, this talk is going to be briefly covering 4 or 5 different techniques, which I will brief in detail. Please note down the points so that we can discuss at the end. If I'm not clear, if you feel free to stop me in between if I'm not clear in explaining any of the points. So before we go on to the implantless economic techniques, let's see how I went and got into this stage. How did I evolve to get these techniques? So before I went on to the ligament reconstruction, as I was doing a lot of trauma, we had a lot of fracture of patellas, a lot of comminuted fractures of patella. Usually, this is a conventional way of fixing the patellas. Certain comminuted fractures, as you can see there, you cannot see any implants over there. So these fractures were actually fixed with sutures. A lot of sutures. When it's comminuted, the initial treatment which used to be was patelectomy. So, but with the techniques of these high tensile strength threads, we were able to get these sutures in place, just not the tension band principle of just a horizontal fracture which is brought together. All the pieces of the comminuted fractures can be brought together with these techniques, and it could give us a stable fixation. This made us use this technique more regularly for more different kinds of patella fractures, even for the regular transverse fractures of patella. So we went on to do for more comminuted fractures, and more techniques were evolved and adjusted. The type of sutures were used, and more cuff sutures, insufflate sutures were added on. This was more versatile in bringing those fragments together, especially those stellate fractures. And more so when there's avulsion fractures, when the inferior pole is avulsed, we can use these Krakow sutures, or superior pole is avulsed, we can use these Krakow sutures and get those fragments in place. We did have certain complications of CQ2 harvest. Even in those cases, we use these fiber wire or high tensile threads, and we avoided a metal implant in those cases. In osteoporotic bones, we did use them. It gave us a good result, but we were a little wary whether we were doing the right thing in the initial cases. So we did animal testing, bovine model testing with the instrom, and we did find that the tensile strength of these, both in cyclic loading as well as loading to failure, were almost comparable with the stainless steel, but were a little inferior to the SS wires. But the strength was good enough for the physiological load of the patella. So given that, we continued to use them, and we did follow up these cases. Because the tensile strength was slightly less than SS wires, we delayed the mobilization. The mobilization was not as quick as the SS wires, which will be around 3 weeks. We delayed it by 4 to 6 weeks. So with this, we were sure of the implant free techniques of the threads are strong enough to hold these fractures. So when we can hold these fractures together, why not we extend this to other areas? Similar thing was the chondral defects. For those patellar instabilities which come with loose fragments, where there's a loose osteochondral defect. When the defects were small, initially we would discard them and think of reconstructing them. But we thought that's the best possible fragment to put back, which is anatomical. We did use the biopins and Herbert screws. But for the small patellas, the screws were too long, and biopins and K-wires were not strong enough and robust enough. So these kind of suture bridge fixations, the same as what we did for the patellar fractures, we can use them with these transosseous sutures. Only tip is that you have to freshen the base so that the fragment sits well, temporarily fix them with K-wires, and use these transosseous. This is actually a meniscus mender, which is used for outside and meniscus repair. I've used the same device over here to shuttle or railroad the sutures. You can use a regular spinal needle also for this, where I've used 0 fiber wire in this case. You can use a 2 fiber wire, but you need a bigger hole. So all these transosseous sutures were placed across the fragment. And as this was a patellar instability, you might need to add an MPFL reconstruction. This is another video, a case example where you can see those threads, multiple threads used as suture bridge, where all angles of the free edges are covered. And you should make sure the knots are not placed on the articular side. So you should make sure the knots are placed away from the articular surface so that that doesn't erode the cartilage. Initially, I was a little wary of using non-absorbable sutures, but with the trochleoplasty, you know, that's usually we use the fiber tape, which is a non-absorbable tape. Initially, I used to use Vicryl for small defects, but now I regularly use these non-absorbable sutures, which are known to give good results and a robust fixation. As you can see, the graft of MPFL is done so that you address the primary issue also. So MPFL reconstruction was done in this case. So here we avoided a screw or any implants, and no need for any implant removal at a later date. So going on to this talk, from such experiences and examples, we did come up with few innovations. To name a few, this paper gives us in brief of all the techniques which were used to avoid an implant, not totally, at least in certain situations, and thus economize the surgery. This is an example where when there is a multi-ligament situation, when ACL is combined with an LCL, lateral collateral ligament, where you need tunnels in the lateral femoral condyle. We thought of confluence of the tunnels. So then on, we thought, why to try to avoid confluence? Why don't we use the same tunnel for both grafts? So we call this as confluent technique, where a common tunnel is used for both LCL and ACL, where the tunnel is drilled from outside in. So that outside point is the LCL anatomical point, and the inside point is the ACL footprint. So you need to use an outside in jig in this situation. Similarly, when you are doing a PCL with an MCL, in the same manner, outside in drilling of the PCL, where outside point is the femoral anatomical point and the inside point is the PCL anatomical point. For the LCL, similar for the distal fibular fixation, usually you need to fix the fibula end by cinching the graft around itself, coming around the fibula head. You can avoid an implant over there. So when an isolated LCL reconstruction, you can avoid an implant in the fibula by cinching the graft onto itself and just using one implant on the femoral side. This has proven to be quite strong in the cases which I've done so far, but it must be an isolated LCL and not within PLC. And another technique where you can use is this MPFL reconstruction. I'll talk in detail about this, where the patellar fixation is just using transosseous high tensile strength sutures, and no implants are used in the patellar side, but still use an implant on the femoral side. We'll talk in detail about this. And apart from that, ALL, which is commonly done for grade 3 pivot along with ACL, you can avoid an implant. We'll talk in detail about ACL with ALL in this talk later on. And MCL, when you have distal avulsions in Steiner's lesion, it's a clear-cut indication for repair. You usually prefer using a suture anchor, but in case you really want to avoid a suture anchor, you can still use these threads, make transosseous tunnels and two parallel tunnels, and you can tie it across in the lateral side of the bone. These are few of the techniques to name. So the same principle was, it's quite popular in ACL avulsions. So when you're using the bone avulsions to be pulled back and fixed, this suture bridge technique has been a routine now. It's become a standard. I don't think many are using the screws or staples any longer. But the advantage of suture bridge is you do not need to remove the implant, which is most of the time mandatory when you're using an implant in an ACL avulsion situation. So apart from that, there are situations where this suture bridge, I would call it suture web technique, becomes an advantage in certain situations. Especially, I will brief them when normally this suture bridge technique is where you make two diverging tunnels just close to the crater of the avulsion. And through those tunnels, suture bites are taken through the ACL or in front of the ACL and brought down and tied on to the medial cortex. But as you can see in this video, those are the cases where you need to freshen the base so that you remove the clot, you have good reduction of the fragment onto the crater. Sometimes you might need to deepen the crater to achieve a good reduction and temporarily fix those fragments with K wires so that you have space for maneuvering the threads. So two diverging tunnels are placed just close to the crater. This was the initial few years back. We used to place the tunnels in either sides of the crater, but now we've slowly evolved to place it more anterior. It's anteromedial and anterolateral tunnels, and the threads are pulled forwards. We find that to be better in seating the fragment down. These are standard fragments of medium size, and the sutures are shuttled through these, and one suture is shuttled through the substance of the ACL and brought down. There are modifications in this. Sometimes there might be lateral meniscus root avulsion with bony fragments. Lateral meniscus root needs to be brought down, otherwise it will be lifting up. So you can add another suture to the lateral meniscus and bring it down through the same tunnel, or bony avulsion of the lateral meniscus, which is not possible with the screw fixation. Sometimes you might end up excising them, but with this technique, you can bring it down still. If the fragment is comminuted, screw fixation becomes really difficult. In those situations, you can add few variations of sutures where you can still bring a suture through the anterior cortex rather along with two tunnels in the bone and bring it down and tie down the anterior comminuted fragment also. So these are the reasons which I try to call them as suture web technique. Along with these, you can add sutures in various angles and try to reduce the fragment. If the fragment is too small or too deep, you might end up coming through the crater. So if your tunnel is coming through the crater or the threads are coming through the crater, it might tend to lift up the fragment and there'll be loss of reduction or no improper reduction. To avoid the crater base, in those cases, if the crater is too deep, you can enter from the lateral side rather than from the medial side. One tunnel from the medial side, another from the lateral side will help us avoid this problem. Apart from that, if the fragment is too large, you might not be able to get to the edge of the fragment. You can still drill through the fragment and get your threads through the fragment. If this is too small, if it's very, very small fragment, you can take multiple sutures through the substance of the ACL using suture passing devices or piercing suture retrievers like the Scorpion or First Pass, so that you can pull down the fragment along with the ACL and you have a robust fixation. So these are modifications which are possible with the threads, which is not at all possible with screws. So this helps us get an anatomical reduction. In an ACL avulsion, getting the fragment back in its base without impingement is the key. So with this, we did find that this has become the workhorse for procedure for all ACL avulsions with all those variations which I've mentioned. So from ACL avulsion, which is a bony, before going on to the next one, so the same principles were adopted to MCL bony avulsions also. So the same can be adopted to patellar tendon distal avulsions also, where running sutures can be placed and transosseous fixation. So it's just not for ACL avulsion, it's for PCL avulsion, MCL avulsions, as well as patellar tendon avulsions. So going on to the next part of the lecture, where anterolateral ligament reconstruction. Why should we know this? So anterolateral ligament is a ligament which is not recently being discovered. It's been there all the time. It's there in the literature. It's a thickening of the anterolateral capsule, which adds a rotational stability. So for any case of an ACL, we should do an examination under anesthesia, because when you check the patient in the clinic, we might miss a grade 3 pivot. So normally there is an anterior as well as rotational movement in the tibia. As you can see, that's the reduction of the subluxed tibia. This is grade 3 pivot, which most of the time will be evident only under anesthesia. Rarely it is evident even in the OP. If you're able to get this in the OP, you should be prepared to do a LET, lateral extra-articular tenodesis, or ALL. Any of the procedures is a must. There are a lot of literature working, for and against each one of them. But for a grade 3, it is generally considered to be mandatory. Hyperlax or revision situations are other indications. A grade 3 pivot might happen even in the presence of medial meniscus, posterior horn tears, or impaction fracture of lateral femoral condyle. So you should be aware of the other causes for grade 3 pivot and make sure those are also not coexistent. If that is not there, it is always better to add a ALL or an LET. There are various authors with various procedures where the procedures of passing the graft under the LCL is described by certain authors who claim that is mandatory, and certain authors mention that it is not mandatory. And tibial fixation point, it's mostly fixed. It's somewhere between the fibula head and the Gerdy's tubercle, about a centimeter below the joint line. But the femoral fixation literature is varied. It is a point proximal and posterior to the lateral epicondyle. So some claim it to be a little higher, closer to the IT band insertion points. Some claim it to be a little posterior and down, but it's a point which is posterior and proximal to the lateral epicondyle. So in the way that we do the ACL reconstruction, where we hyperflex the knee and make an anatomical transportal femoral tunnel, our endobutton exit point is here, where you can see the blue point marks the lateral epicondyle. The button is proximal and posterior to the lateral epicondyle. So we thought, why not use but avoiding that point by making another tunnel is a difficult task, especially in a small knee. In a large knee, you might be able to get away. In a small knee, it's really difficult. And as we already saw, why not use that same point and use the same tunnel for an ALL? So that's how we came out with this. In our technique, we tried to make a longer tunnel. We had a study of how to get a long tunnel in these short females, where we found out hyperflexion and drilling it the guide wire as parallel to the floor and maintaining an axial angle of less than 45 degrees gets us a long tunnel. So based on that technique, our exit point usually is in the postero superior quadrant of the femur in the lateral view, which is always posterior and proximal to the lateral epicondyle. So this is the way we prepare the graft, where symmetry is taken in quadruple and gracilis is added as a single strand. So after the endobutton is passed, that's the quadruple symmetry, and a single strand of gracilis goes along with the endobutton fibers, as you can see. So for this technique, after passing, this is the bead pin coming out of the femoral tunnel out of the skin, and the bead pin is not fully taken out, and the point of the bead pin helps us to palpate the exit point from the femur, and fascia lata is opened, and the same arthroscopic view where you can feel the bead pin, and the bead pin has this thread or a nitloon loop which is retrieved from that point, and it is got out of the lateral side, and the graft, gracilis graft, and the endobutton threads are pulled along the 4.5 tunnel. So the gracilis graft must be thin enough to be taken out of the 4.5 central tunnel, and a larger tunnel of the final graft size, which should be 8 or 9. As you can see, the graft is coming out of the lateral side along with the threads of the endobutton. Both are pulled out, and the length of the graft should be around 20 centimeters. I'll explain why. And you can see the button going along with the gracilis. I will tell you the complications which we faced with these steps. And again, you need to make sure the button is flipped and the graft is under the button, so that the graft is also fixed at the femoral side. The graft should not be over the button. As you can see in this picture, the graft is below the endobutton. If the graft is over the endobutton, the button tends to get deflipped. So, and then the fibula point is made, where it is a centimeter below the joint line between the Gerdy's and fibula head. The drill wire is passed from this point towards the medial opening where the ACL footprint is there, and the graft is passed deep to the TFL, but in this case it's superficial to the LCL, which is the ALL. I do not try to pass it deep to the LCL in this technique. And the graft is retrieved through the distal insertion, and the bead pin, which is already there, which end comes to the medial side, which is the same just below the ACL tibial tunnel. The graft is passed over there, and the threads are tied onto the ACL threads which are coming out of the tibial side after fixation. To make it a little more clear, this graphic will help us understand. The ACL and the ALL are passed through the tibial tunnel out of the femoral tunnel where the button is flipped, and then the AL is brought down out under the TFL onto the tibial side and back to the same incision point where fixations of the ACL is done by that button, and then ALL is done here. The proximal fixation of ACL and ALL is with the button over there. ACL is fixed to the screw over there, and ALL is fixed by tying those threads together. So that's the technique of ALL, and you should make sure your length of your chrysalis is 20 so that it is able to reach. If it's too long, you might need to trim it so that you'll be able to tie it to each other. By this, you can avoid an implant for ALL. There is no extra implants involved. The advantage being that you do not need to worry about finding a grade 3 pivot interop. You can still get away with the same implants. And explaining the patient is also easy because incision also very less. So this is one of the complications which I had where the button had deflipped in spite of checking it. So when we went back and checked those videos, while passing the graft, we should make sure the button is in front and your graft is behind. That should be the other way. The button should be behind and the graft should be in front. So then only the button will be flipping over the graft. So from then on, our technique changed. So we make sure the graft is anterior and the button is posterior. And as you know, there are a few complications of lateral like static tenodesis or ALL. There might be over-constrainment of the lateral compartment, but with the right indications, I don't think it's a problem. So ALL reconstruction might not be a common procedure, but very useful in high-grade pivot or in revision situations. With this technique, there is no need for additional implants or any additional grafts. Rehab, it's the same. But regarding which exact technique, there is no clear consensus. We have had good results with this technique so far. So this is one of the confident techniques. The examples of other confident technique, I would like to show this case, which was a learning point. And from then on, we went on to do this particular case where she had come to us about 40 years female. She had come to us about 3 months post injury. The fracture had not yet healed, but she was unable to stand because of full house, ACL, PCL, LCL, and PLC. And there was a nail in situ. Because the nail in situ and they had dynamized, and you need to weight bear for that fracture to heal. She wasn't able to weight bear. So she was stuck in a situation where she wasn't able to weight bear. She wasn't able to walk, and she was wobbly. So because of the knee instability, so we cannot take the nail out. We needed to reconstruct the ACL, PCL, LCL, and PLC. So how to go over there? There was an avulsion fracture of the LCL. There's another screw over there. So planning for this case. So you know how to deal with the multi-ligament situations. There's a very good paper by Moche et al. Where it tells us how to deal with the multi-ligament tunnels in the femoral side, medial as well as lateral. But in a small knee, this itself is so complicated. So it becomes really more complicated in an Asian population. In a large knee, it's okay. Asian knees are known to be smaller. So getting that in an Indian patient was really difficult. So just not that, you add a nail over there and a couple of screws and another screw over there. So imagine a situation where how can we deal with that in the lateral side, where there is an LCL, there is a PLC, and an ACL to be done. And the same goes to medial side. Maybe MCL is spared. So for this situation, we did came out with a plan where the graft options were for the PCL, the opposite CQT, the central quads tendon, and for the ACL, the opposite contralateral ST&G. Being a female short, we thought we might need both, and the ipsilateral CMT for the PLC. So femoral tunnels. So for ACL and LCL, as I mentioned, we tried to use the confluent tunnel technique, where you use the same tunnel so that there is no divergence, and by taking the tunnel towards the intra-articular, we can still avoid the nail, which is slightly anterior. So how much hardware to remove again had to be decided, because the fracture is not yet healed. You cannot take all the screws out. So that was a situation where the screws were anterior, nail was in the center, your tunnel for the ACL and LCL is just behind. So that's how we got away with that. And we were lucky to see the screw in the margin of the tunnel. And again, for the medial PCL and ACL tunnels were made as shown here. I'll go through them quickly. And both the grafts were passed into the same tunnel from outside in the LCL graft, which is seen in the tunnel already, from inside out the ACL graft. And that was fixed with the single screw. So this was a very good case where we can retain the screw, and that was the post-op X-ray. And this patient did recover well, and that was the immediate post-op. That was the follow-up, and she did walk well after 4 months of follow-up. So with the proper management of tunnels, you can get away with such situations. And this confluent tunnel technique helps us avoid an extra implant and helps us achieve tunnels in anatomical positions when the knee is small. So we had found this to be very useful. Going on to the next part, where I'm covering the patella MPFL reconstruction. As I already mentioned, there is no implant involved in this one. So we can see over here, I'll go through this quickly. There are so many hundreds of techniques described for MPFL reconstruction. Few implant-free techniques where you drill the tunnel through the patella, take the graft through the patella. But if the patella is really small, you cannot take the graft through the patella. You need a bigger tunnel. So for that, you can just take the threads through that, where you need only a 2.25 or 2.5 tunnel. So when you drill two parallel 2.5 tunnels, you can just take the thread into it and tie it onto the medial side. This is the simple way of avoiding it. I'll go through this technique quickly. Two parallel bead pins are placed, and these are open bead pins which help us retrieve these threads through a small incision made medially, a loop, and two free ends are there in the free end medial side, and the femoral point is made through this Shortle's method. But now I stopped using Shortle method. We find the anatomical method, the point between medial epicondyle and adductor tubercle, to be more consistent with the isometric point. So the graft is fixed with these two threads in the patella side, and the free ends are passed in the femoral side. And the femoral isometry is checked and fixed with the screw. And the post-op rehab remains the same, and we have found this to be quite successful, and our results have been good. Another example of avoiding an implant is an ACL with HTO, where we combine these procedures in varus knees with early OA changes with instability. When your tunnel, avoiding the tunnel is a challenging task, and placing the tunnel, screw into the tunnel again is a challenging task. But you can tie the threads of this graft onto the plate by making sure you have good threads and good knots. But the problem with this is tensioning. With this, when you tie those knots onto the plate, your tensioning is not sufficient. You might end up loosening. To avoid this, you should probably use an adjustable loop proximally. So when you pass the adjustable loop button proximally, do not tighten it fully. Fix it distally, then tighten the adjustable loop proximally, so that you get full tension in the ACL when you're not using any screws in the tibial side. And as a last example, I would like to show this, even though this is not a ligament reconstruction, it's a very useful innovation or economical procedure where oblique flap tears of meniscus, we usually end up excising them, as in this case. This is an oblique flap tear. Repairing them is quite difficult. So this technique where you pass one needle with 2 pairs of threads through the same hole and use these radial configuration of sutures, you will be able to achieve good reduction. This is economical in the sense that you just use 2 threads for 4 sutures, but for this you need these open eyelet needles. So you can cut the threads and use it again also, so that it becomes economical. So this is essential to have these open-eyed needles with you to follow this procedure. These are videos of how it is done. The open-eyed needle is there, and the 2 pairs of needles are placed as the needle is passed and retrieved the other side. You get 4 threads going through the same hole, and the rest of the threads are passed one by one on radial fashion on various points of fixation around the parrot beak tear. So I've almost come to the end of the talk where I've elaborated all these techniques. For more details of this, briefly, this paper highlights almost every aspect of this talk. You can go through this for more information. Thank you very much. I hope I didn't bore you a lot.
Thank you so much, Professor Santosh, for this very interesting presentation. We have Professor Srinivas as a moderator of this session. Professor Srinivas, please, sir.
Thank you very much, Dr. Santosh. That's a very interesting presentation. Thank you for the excellent presentation. I'm sure these techniques will be very useful to surgeons in resource-challenged situations and towns. And Indian and Egyptian population being similar in terms of heights and measurements, these techniques will come in very handy in special situations. There is one question from one of the delegates. We'll go through that first. I have a few questions as well. In fracture patella, this is from Dr. Gamal Qasim. In fracture patella, is there a specific depth for suture passing to preserve the alignment of posterior surface and the ideal post-operative position in case of using suture technique?
The depth of the wires and threads are same as any K wires for TBW or tension band wiring, where it's about half the depth of the patella, not to go close to the cartilage. But while fixing them, you need to place your fingers inside and check for the cartilage alignment so that there is no step in the cartilage. Your superior surface can have steps, no issues. But more important is your articular surface. So you must have some kind of access. If you do not have access, either use a C-arm or you can make a rent in your retinaculum to get your finger underneath and feel the step in your cartilage. So that's the priority for any patella fixation. There should not be any step. Gap is also acceptable, but step is not acceptable. That's the first part of the question. Post-operative rehab, yeah, extension. Patella fractures in extension in a brace. I don't cast them. I keep them in a brace for at least 4 weeks, and depending on the fixation strength and the fracture pattern. So if it's really robust and just a transverse fracture, can mobilize by 4 weeks. It's a vertical split. I mean, you can mobilize early, much early. Usually vertical split, you don't fix them. It's the intra-op complications of PTB harvest, whichever I showed. If it's that case, you can just fix them and still continue to do range and partial repairing.
Do these sutures get loose over time? What's your experience?
I did have one case which did loosen and
or lose or get stretched over time?
It gave way. The ethibonds gave way.
Mm-hmm.
So the reason I try to use ethibond is again economics, where We have 5 pairs of ethibond sutures. You can use the other sutures. We'll have only 1 thread, so we need to keep on using more and more threads. Fiber tapes are much stronger. It's better. The knot techniques and getting the tension onto the knot is the difficult part in this one. So there are certain tensioning devices which are available for tensioning these threads. There are certain for humerus shaft fractures, to get those fragments together, there are certain tensioners just to tension these threads all around. Getting the tension and holding the tension is the difficult part in this one.
So you've not faced any loosening when you started?
I did. I
Fiber
have one case of loosening
with fiber wire. Okay.
With fiber wire, and I've done one for the olecranon. I did have a olecranon. Still, it did loosen triceps.
Okay.
It did loosen, so I had to revise it with the screw, but still it didn't heal with the screw. And the patella I had to revise with the TBW, and it did heal.
And is there a chance of cutting off of the sutures by the sharp edges of the bone especially in the suture web fixation of your tibial avulsion fractures?
No, we've not. There we use the high tensile strength ones, which are quite strong enough. And now we are using it through the fragment, through the ligament substance. Regularly. We don't just place it on the bone. We do take them through the ligament substance. So there is no cutting through as of whatever I've had experienced.
And coming to the confluent tunnel technique, you're saying, when you are using confluent tunnel, one graft will be coming out and one graft will be going in, isn't it? They are from different directions. How do you hold them and fix them in the single tunnel?
Yeah, good question. Now, if it's an LCL, LCL had to be passed first from outside to inside. Your tunnel must be slightly larger than both the grafts added together. And that has to be got intra-articular, and it will be pulled out through the portal. If your viewing portal is anterolateral, you have to pull it through your medial portal, or get an accessory portal and pull the graft, and then pass the other graft through. So both graft added on, your tunnel size might be slightly larger, and your screw fixation screw also might be slightly larger.
So you measure the graft diameter with the block before making the tunnel.
Both added together.
And how do you hold these? So you hold one from both sides, and you pass the screw.
Yeah.
From the outside.
So both are different. So suppose if it's an LCL and an ACL, LCL has to be fixed in extension, and ACL has to be fixed in slightly flexion. Yes. So this fixation is the first fixation. You don't fix the other end. So you fix the femoral side and get it into extension and fix the tibial for the LCL and slight flexion. In the same way, for a PCL, the femoral side is fixed, then MCL is fixed in extension and PCL is fixed in flexion.
Also, the grafts have to be held in tension when you're passing the screw, isn't it?
Yeah, correct. So that's the difficult part. Both ends, somebody must be holding it and then graft. Yes. Screw is passed outside in.
Yes, yes. Interesting. Regarding LET versus ALL, which one is your preference?
I prefer using the ALL because the incision is less. We've had good results. We did try LET in my early days. I did have quite a number of stiffness post-op, which might be, outliers or something. So there is apprehension towards using LET, and the incision is larger. Explaining the patient post-op is slightly difficult because when we notice them intra-op in examination under anesthesia, we had explained an arthroscopic procedure, and there's a big scar on the lateral side. Sometimes they are unhappy. So, and implant is an extra implant. So considering that, we do not hesitate when we do an ALL to add this to the patient because explaining becomes easy for us.
When you do ALL reconstruction, can we use fiber tape in place of gracilis?
I don't prefer using any of these tapes or threads, non-absorbable sutures crossing the joint in any of the situation. Absorbable sutures may be okay, along with biologicals, adding suturing the graft is okay, anything biological, but just a non-absorbable thread across any joint. My thinking is that over time they would enlarge the tunnel or cause wear in the tunnel. That's the reason for all these techniques. They do not advise you to fix those. If at all, if you're adding a thread, do not fix them same as the graft. Fix the graft, fix this thread slightly looser than, so that it prevents you from overstretching. So that is not the primary stabilizer. It is an additional thing which will prevent overstretching. If you make it too strong, it's going to enlarge your tunnel because it's not biological and it will not get absorbed. So that's my thinking. So I did not advocate when it's crossing the joint.
And the one with the HTO plate. Sorry, I didn't get that clearly. Did you use a adjustable loop on the tibial side as well? Were you
the distal
not
end
the
is
one you
fixed.
demonstrated?
The distal end is just tied to the plate as a aperture fixation. There is no screw in the distal end. Again, tying those threads onto the plate, tensioning is very difficult. You might lose the tension of the graft. So to avoid the loosening of tension, when you have an adjustable loop proximally, where you do not tighten the adjustable loop fully in the beginning, you
So
leave
proximally, did you mean on the femoral side or?
the femoral side, you pass a adjustable loop,
Okay.
take it inside, leave 5 mm more so that you can tighten it at the end of the procedure.
Won't fully tighten it. Okay.
Don't fully tighten it. So you
Okay.
fix it distally and fully tighten it so that you get the full tension.
Right. Okay. Okay, that's great. Thank you. Professor Elashab, do you have any questions?
Thank you so much, Dr. Srinivas. Thank you so much, sir. Finally, I would like to thank Professor Santosh for his very interesting presentation. Thank you so much, sir, for accepting our invitation. It's an honor for us.
My pleasure. It's an honor for me too.
Thank you so much, sir. Thank you. Our next speaker will be Professor Rahman Elganainy from Mansoura University. Professor Elganainy is one of the eminent speakers and eminent professors of knee surgery in Egypt and the Middle East. Professor Rahman, please, sir.
Thank you, Dr. Okay. First, I will thank to Dr. Ashar for this nice invitation, and Professor Sahanand, and this very nice meeting every week. And I hope to give a nice presentation. And I hear the presentation of Mr. Santosh, very illustrative and very beneficial for us. Thank you for his presentation. Now, I will speak about something about the knee. It is controversial about knee instability with ligament, knee instability with varus malalignment. This title is very important in orthopedic surgeons who deal with the knee ligament injury. When patients have instability, have varus deformity, because many of this surgery may fail if the surgeon did not address the varus instability. And Mr. Professor Santosh had one case like this, and he did osteotomy and ACL reconstruction at one sitting. And we'll see the controversy about management of this issue. Knees with chronic instability pose a difficult treatment challenge, and in all cases, the contribution of coronal plane alignment, varus valgus knee instability must be carefully addressed prior to ligament surgery. And also sagittal plane alignment is also an important key and must not be overlooked. The ligament laxity is often complicated by the presence of bony abnormalities and degenerative changes, and treatment of these patients often requires more than ligament reconstruction. The alignment with medial can hold the progression of arthritis in the midterm, in the medium midterm. And there are still controversies, as I said, about combined ligament intense with varus aligned compartment arthritis. Varus alignment is a common finding, and the type of varus, primary or double and triple varus, must be determined. Individuals with a pre-existing malalignment of the lower limb and significant knee ligamentous injury may not go well with an isolated ligament reconstruction, as we said. Important issue in patient with varus malalignment, the neuromuscular or proprioceptive control of the joint provided by the soft tissue structures may be lost when the ligament disruption occur, increase malalignment and subjective instability, and in this alignment surgery augment ligaments reconstruction and improve overall joint function. In the ACL deficient knee pre-existing varus malalignment progressive lead to progressive medial compartment degeneration or medial meniscus injury, and this may lead to medial compartment narrowing and the weight-bearing axis may shift medially, and this will lead to primary varus. And so in ACL deficient knee, the primary varus is very important, and with progressive and posterolateral structures become more lax and lead to double varus. If the malalignment is chronic, the overload on the posterolateral structure may lead to hyperextension recurvatum varus. And so to this varus, primary varus is referred to overall tibiofemoral varus osseous alignment, including medial meniscus degeneration and also articular cartilage degeneration. But in double varus entails varus osseous alignment combined with the separation of the lateral tibiofemoral compartment due to lateral ligament damage. While in triple varus, the patient has tibiofemoral osseous alignment, increased lateral tibiofemoral compartment, but he had also recurvatum and external rotation, and external with involvement of the entire posterolateral ligament complex. And so the first varus osseous and the second varus is lateral compartment and enlargement due to but the third varus is associated with hyperextension and PLC deficiency. In double varus, when you see the X-ray, there will be increased lateral joint opening by about 4 millimeters, but in triple varus, it demonstrates further lateral joint opening by about 8 millimeters. Varus thrust is very important when you examine a patient with ACL injury or ligament injury, peripheral ligament injury. You have to check for varus thrust. The varus thrust can increase tension in the ACL graft and lead to failure of the graft if you didn't address it. This patient had a varus thrust, as you see. Look, with each weight bearing, when the affected leg is on weight bearing, the knee thrust is outside. As you see, the knee goes outside with each step. You can see the reverse of varus thrust is valgus thrust in patient with medial ligament deficiency. As you see, the knee will go inside into valgus. So in ACL deficient knee, the medial compartment tend to have a posteromedial tibial plateau wear pattern. As you see in this arthroscopic view, this patient had ACL deficiency, and you can see this is the medial meniscus, and the posteromedial part had grade 4 arthritis. When ACL deficient knees with ACL deficiency and the varus can progressively stretch their lateral structures, resulting in further dynamic varus on top of varus. As we see in this arthroscopic views, this patient had ACL deficiency, and you can see this posteromedial wear on the medial compartment, and also the patient had an ulcer on the femoral side. Also in ACL deficient knee, the patient with combined varus malalignment and ACL laxity represent a complex scenario. The ACL injury has been shown to correlate with development of osteoarthritis, especially in the medial compartment, leading to degenerative varus deformity. And if we do ACL reconstruction, despite good early clinical and functional results, has been unable to be completely secondary degenerative changes of the knee. So the question, is there any benefit in the combined ligament reconstruction with osteotomy compared to ligament reconstruction alone? The role of osteotomy is to decrease the slope to prevent posterior tibial slope to decrease the slope to prevent an anterior tibial translation, and the ideal indication is a tibial slope greater than 10 degrees. The objective of correction must aim for a slope between 5 and 8 degrees. So in ACL deficient knee, combined HTO and ACL reconstruction may be indicated in patients with ACL deficient knees with varus angulation, and the many systemic review found that the combined surgery resulted in significant improvement in post-operative functional subjective outcome. However, it remains unclear if high tibial osteotomy with ACL reconstruction is superior to ACL reconstruction or high tibial osteotomy alone due to lack of comparative studies. As I said, there is a dilemma, there's controversy in this issue. Some surgeons do ACL reconstruction first and then followed by high tibial osteotomy. Other surgeons do high tibial osteotomy and they decrease the slope, and this patient may do well and didn't need ACL reconstruction later on. Radiographic evaluation, you have to do AP views in extension, tunnel views, and 30-degree flexion, Rosenberg view at 45-degree flexion, lateral and skyline views, and also weight bearing, hip, knee, ankle AP view is very important. And also to do AP view, standing view, and lateral view also. Lateral view provide important information about the posterior tibial slope. And in the sagittal plan, you have to address the slope and to measure the slope of this patient, because increased tibial slope is a very risk factor for ACL failure. As you see in this patient had ACL, AP, and the lateral views. The AP view showed medial joint narrowing, as you see, and osteophyte, and the lateral view shows increased or exaggerated tibial slope, and this was the cause of failure of the ACL. And another question is raised: is there a role for bony correction in primary ACL reconstruction? In primary ACL reconstruction, in patient with constitutional varus, no role for high tibial osteotomy, but you have to address the degree of varus. If it is more than 3 to 5 degrees in of tibial slope, more than 12 degrees, and the malalignment, the coronal and sagittal veins have been implicated as a primary contributing factor in graft failure. You have to know this patient may have a graft failure after reconstruction. While increased tibial slope may increase the risk of ACL graft failure, as I said, alteration of posterior tibial slope is typically not recommended in association with primary ACL reconstruction. In ACL reconstruction, of the surgeons recommend to do just ACL reconstruction without addressing the tibial slope, except if it was more than 30 degrees, 12 degrees. But in cases with triple varus and patient have varus rust, you have to correct the osteotomy. You have to correct the deformity. This photo can summarize the causes of the ACL failure. As you see, maybe through the meniscal injury, medial meniscus degeneration, medial meniscus partial meniscectomy, or ram tear or root tear, and also a peripheral ligament injury in posterolateral coronal injury, as you see in this Trife-Stroff arthroscopic view, and also in medial side injury, as you see, and also in increased tibial slope, and also in patients with varus deformity. So the indication and rationale for high tibial osteotomy in peripheral instability. We summarize the ACL deficiency in primary ACL in constitutional patient with constitutional varus, no role for osteotomy, and you can do just ACL reconstruction, and you have to tell your patient that your ACL is in danger later on because of this increased tibial slope. But if the patient have varus rust or triple varus, you have to do correction of the varus deformity. And if the patient had varus angle more than 5 degrees and tibial slope more than 12 degrees, you can do combined ACL and correction of the deformity. And we can now say high tibial osteotomy may be indicated in patients who have posterolateral laxity and varus hyperextension thrust, ACL deficiency and varus thrust, combined ligament laxity with varus or posterolateral thrust. In these patients, poor results with the ligamentous reconstructive surgery alone. And so opening wedge or closing wedge, which of which? Opening wedge high tibial osteotomy is better technique comparing to closing wedge high tibial osteotomy. And the reasons include, number one, possibility of a multiplanar correction is more easier than lateral closing wedge osteotomy. No need for proximal tibiofemoral joint disruption or fibular osteotomy. And this spare one step is the surgery, less risk to the common peroneal nerve, and also possibility of limited surgical approach on the medial side of the knee. As we know, the high tibial osteotomy is an easy procedure. You can do your incision between the lateral border, the medial border of the tibial tubercle and the posterior border of the tibial border, and you take the halfway between them and you do your incision, and you release the medial ligament, and then you put your wire to assess your line of osteotomy, and then make your osteotomy. Closing wedge high tibial osteotomy usually result in decreased slope, but it helps reduce the stress in the new alignment and faster callus formation than with opening wedge high tibial osteotomy. And so we can use it in patients with poor bone healing. Amount of correction. This is also another point of controversy. The aim of correction may differ depending on the underlying pathology. In ACL deficient patients with varus malalignment and thrust, the correction may be aimed at neutral leg alignment. Here you have to do a neutral alignment. While in patients with varus malalignment and unicompartmental medial osteoarthritis, the aim is often to correct into valgus leg alignment to unload the damaged medial part of the joint. And so in patient with ACL, neutral alignment, but in patient with osteoarthritis, you can shift to valgus side. Amount of correction also in active patients who hope to return to high activity level. The goal of correction may be a weight bearing passing through the center of the knee, want to shift to a valgus side. Even in the presence of medial cartilage damage, because overcorrected leg would interfere negatively with their athletic abilities. As we know, the effect of osteotomy in the sagittal plane, the axial load of the knee interacts with the posterior slope of the tibial plateau, and the contact force may be resolved into compression force and shearing force. And this shearing force component causes the femur to move posteriorly down the slope of the tibial plateau, which will tend to stretch the ACL graft. When the femur with increased slope downward and become backward, and the tibia become upward anteriorly, and so this causes stress on the ACL graft, as we see. This is the ACL, and if the slope is increased like this, the tibia will shift anteriorly, and so the stresses will be increased over the ACL and will be decreased on the PCL. Advantage of decreased in posterior tibial slope, it will decrease the forces on the ACL, and the tibia shifts posteriorly, as we see in this photo. After correction of the slope, decreasing the slope, the anterior slipping, the tibia coming backward, and the stresses is decreased on the ACL. And the advantage of increase in the posterior tibial slope in case of PCL injury, the force of the PCL will decrease, and the tibia shifts anteriorly, as you see in this photo. Failed ACL, you have to address all the causes of possible causes of failure. Long leg anteroposterior and lateral radiograph this X-ray show for a 35-year-old male patient. with 2 previous failed ACL reconstruction, and the cause was the increasing tibial slope. There was no problem in the tunnel or anything, just the increased tibial slope and the varus malalignment. So to do high tibial osteotomy alone or high tibial osteotomy and the ACL in revision cases in one setting, high tibial osteotomy alone or with ACL reconstruction, some also recommend combining high tibial osteotomy and ligament reconstruction and report a favorable outcome. However, high tibial osteotomy with combined ligament reconstruction is technically demanding and needs experience and increasing the risk of morbidity and delay rehabilitation, because patient when the rehabilitation will be difficult. And some authors also report that high tibial osteotomy alone could reduce pain and improve subjective knee joint stability. And if the patient had had instability, prominent instability, he may do ACL reconstruction later on. Some surgical steps in this patients in combined high tibial and ACL reconstruction. You have to do arthroscopy first and to prepare your notch. The femoral tunnel are performed prior to the osteotomy, and then the osteotomy is performed prior to drilling of the tibial tunnel for ACL reconstruction to prevent the creation of a possible stress riser through the ACL tunnel. As we see, we did our osteotomy, and after we do our osteotomy, we fix the osteotomy, and you do a tunnel, your tunnel for the ACL after you do osteotomy, and put some reamer or anything metal to prevent interference with the screws of the proximal fixation of the tibial osteotomy. You have to keep the slope. When you do osteotomy, a posterior placement of bone spreader and posterior wedge or lumbar cage is recommended to avoid increasing the slope magnitude. You have to fix your osteotomy and keep the slope before you fix the plate, because keeping the slope is very important in your surgery. As we see in this patient, we have to keep the slope this posterior more than anterior. In ACL revision cases, as you see, we may introduce your graft through the opening of the osteotomy and fix it by anything like this in the bone, by screw and washer or something like this, to avoid the more anterior tunnel and break through the graft. Post-order protocol in this patient, the plate is used to stabilize the osteotomy. The patient will be to touch weight for 6 weeks, and in this period, the knee will be protected into the brace locked extension. After 6 weeks, X-rays are performed, and if there is no problem, the patient weight bearing is allowed the patient. In PCL deficient knees, the role of osteotomy is to increase the tibial slope, to reduce the tibia anteriorly, and we recommend positioning of the plate in an anterior position, as you see, the anterior position, to make the anterior opening more than the posterior opening by 2:1 ratio. This patient, as you see, pre-operative X-rays, and the patient had PCL injury, and we put the plate in anterior position, and the patient did well and did not need PCL reconstruction. In varus knee with lateral instability and peripheral ligament injury, valgus high tibial osteotomy protects the lateral side in the setting of large varus thrust or an injury to the PLC. In some cases, you may need to do reconstruction of PLC. If the patient has varus thrust and very lacks post-lateral structure, or reconstruction of PLC in combining with the high tibial osteotomy. The varus knee with lateral instability, if the posterolateral structures were relaxed and not completely disrupted, just open wedge high tibial osteotomy without ligament reconstruction may stabilize the knee and avoid the need for ligament reconstruction. And thus it remains controversial whether to perform concomitant ligament reconstruction the time of high tibial osteotomy or not, or you can do your osteotomy, and after that you can examine the stability of the lateral of posterolateral structure to see if you will add PLC reconstruction or not. You have to do preoperative X-rays, as you see, long film, and clinical examination, as we see before, and then to do your lateral exposure. This is biceps tendon, and then to explore the common peroneal nerve, and this is the fibular tunnel from anterolateral to the posteromedial, the shuttle suture, and then to detect your point in the femoral condyle, and then to do your tunnel. After that, this is the graft, and then to fix the graft in the femoral tunnel underneath the iliotibial band. This patient, we did reconstruction of the lateral collateral ligament and high tibial osteotomy. And as you see, we put a lumbar cage, and this proved to be a very good spacer in this osteotomy. And it united very good, and is cheaper than bone substitute. This is another X-ray for this patient, and as you see, after some time, the graft, the cage has taken the bone, and the healing was very good. X-rays. Conclusion: isolated soft tissue procedures provided unsuccess in those knees with significant varus, and uncorrected alignment resulted in repetitive stress and the failure of the surgically reconstructed lateral structures. High tibial osteotomy without ligament reconstruction may stabilize the knee and avoid the need for a ligament reconstruction. ACL reconstruction, despite good early clinical and functional results, has been unable to completely avoid or delay secondary degenerative changes of these knees. Osteotomy still play an important role in chronic ligamentous knee injuries treatment and needs to be considered in the decisional algorithm. Thank you.
Thank you so much, Professor Abdelrahman, for this very interesting presentation. Now we will start our discussion with Professor Elganainy. My first question, sir, from what you have presented, sir, I see that you prefer first to do high tibial osteotomy, and then you assess the patient and see if he's I have to do additional ACL reconstruction and ligament reconstruction, and you do not prefer to do simultaneously both in one setting. I'm right?
Yes. Okay. Dr. Ashab, I did many cases simultaneous. We did a many case series of patients with combined ACL and high tibial osteotomy, and honestly, I see the rehabilitation was very hard, and many patients had stiffness, and we enforced it to do another session of arthroscopic lysis for these patients. And I regained myself again and to do a staged surgery. I did high tibial osteotomy first, and then to do ACL reconstruction. But in some patients, if the patient has good bone and has mild deformity, and I expect him to have a very good rehabilitation, I can do this patient, but rare. And I prefer to do stage surgery in this patient. But in ACL revision, no way to do osteotomy and to correct the slope.
Yes, sir. And in the cases with triple varus, with ACL instability and ACL injury, you do the same procedure, or do you do these procedures simultaneously?
It is some surgeons prefer and some still prefer the other, but I myself prefer stages procedure. We do high tibial osteotomy first, and sometimes you can do also reconstruct the PLC, and then later on to do after not a big time for moderate time, after months, to do the reconstruction for the ligament. And I would say to you, we did some patients high tibial osteotomy, and we correct the slope, And this patient refused to come again to do reconstruction of the ligament. They do well and did not need, they had no instability at all.
Yes, sir. Do you find any difficulty, sir, with making the tunnel when there is a plate maintaining the correction, sir?
Okay. Well, when we begin to do this, we put the osteotomy lower as much as we can, and we put the tibial tunnel more proximal to the osteotomy. But it was difficult, and sometimes the tunnel will be shallow, and when we fix them, it make problem. And then we take the graft through the osteotomy and fix the graft with it more longer, and fix it with stable or screw washer and something like this, and the healing will be very good, no problem at all.
Thank you, sir. Dr. Srinivas and Professor Santosh, you have any questions, sir? You are muted, Dr. Srinivas.
I have a question, sir, if that's okay.
Yes, sir, please.
It was an excellent presentation. Thank you very much, Professor Elganainy. I just wanted to ask, at what stage do you do MRI scans for your patients?
Again, here's the question.
At what stage do you do MRI scans, sir, for your patients?
Pre-operative?
Okay. So you do MRI for everybody, for all
Yes.
the varus scans?
All patient, pre-operative MRI.
What percentage of your patients do you think have injury to the posterior root of medial meniscus? Because Professor Laprad's work has shown a silent epidemic of these conditions. They could be responsible for a rapid OA onset as well.
Yes, yes, as you said, much of them has medial root, posterior root avulsion, and we did a repair of the root. And recently we do a research with gracilis muscle, with the gracilis tendon for repair of the posterior root of the medial meniscus, and it do well.
Do you find, do you repair it with the transtibial tunnel as well? Because if you have a plate, then passing that tunnel also, do you find it difficult?
No, when we do root repair, we do another tunnel than the ACL repair, because it is difficult to put your graft in the same time.
So is it difficult to pass two tunnels with the plate and the screws in the proximal fragment, or how difficult?
As I said, most of them I did stages procedure. I didn't do the same one stage, because in rehabilitation, many of them had bad rehabilitation, and we enforced it to do arthroscopic lysis for many of them. And so we set our protocol to do stage surgery for this patient.
Okay, sir. Thank you.
So very nice presentation, Professor. Just one question: do you bone graft all the cases, or any bone graft substitutes, or how do you decide when to bone graft?
Yes, when we begin this, we do it. We did the harvesting bone graft from the patient, from the iliac bone. And later on, we did a study. We didn't put a graft, and put a comparative study, patients with no graft and patients with iliac bone graft. And we find no significant changes in the result. Patient with no graft had good healing like the patient with bone graft. But indeedly, in patient, you do a big osteotomy and osteotomy angle. We have to do something. And lastly, we did your lumbar cage. The cage, you put it in the lumbar spine. I did many series, 100 of cases with lumbar cage, and the healing was very good. And the patient had no problem, and no one case with non-union or something like this. And if you put the cage, the osteotomy site will be fixed and will be stable, and just you put your plate without any problem. And now you keep the slope as you want, no change in the slope, and put your no need for assistant to hold the leg, and just you put your plate and fix it easily.
Professor Abdurrahman, we have one question from Dr. Muhammad Hamid. What about Cora in varus knee? Are the high tibial osteotomy doing out of the testing?
Yes, in our cases, most of them is medial compartment osteoarthritis. And so we do for all cases the high tibial osteotomy, okay? And with degree of correction, as I said, here we are not dealing with a deformity, a patient with a deformity. We deal with a patient with ligament injury. And so in athletic patients, we just do for the neutral alignment. And the patient with osteoarthritis, we just do the valgus side. And in athletic patient, no, we didn't do osteotomy to the valgus side, just to the neutral alignment.
Do you do any form of fixation after the operation, high tibial osteotomy, when you are fixing with the plate?
Yes, I do with Tomofex. This titanium plate is very good, with 3 holes in the proximal part and 5 holes in the distal part.
No, I mean slab or cast or.
No, just base. No. External support, just a base.
Just the base.
3 weeks, and the patient can move his knee about after 1 week. You can flex and extend the knee. And I put, as I said, after 3 to 5 weeks, patient can put his leg on the ground.
Do you use any other types of plates, sir? Any other fixations? Apart from Tomofex?
No, we have in our institute, we are more just to have fixed way of fixation, fixed way of other, and then if we can, we do this to have to make it easy for research in our unit.
How about unicompartmental arthroplasty?
We have just one thesis, MD thesis in our unit, unicompartmental. They did about 30 cases as in last 2 years. But the problem is with implant is much expensive and something like.
How do you choose between uni and HTO?
Indeedly, my colleague did this research, not me, but he have some things to do unicompartmental patient to selective with have medial or lateral compartment. And indeedly, he had to answer you.
Yes, can I answer this question, please, Dr. Sarnivas?
Yes, sir.
Because I have already just attended the unicondylar knee replacement in Keble College in Oxford about 4 months ago. The key for success for the unicompartmental knee replacement is the proper patient selection. I have to have something like prerequisites for making a unicompartmental knee. First, we have bone on bone in the medial compartment. If there is no bone on bone, I have to go for arthroscopy or high tibial osteotomy. If I have bone on bone, so I have to do unicompartmental knee. I have to have the patellofemoral affection. The lateral part of the patella should not be affected to a great extent. Also, although there is a controversy, now they are speaking about that the patellofemoral affection is not a contraindication to do unicondylar knee replacement. I have to have a functioning ACL, of course. The varus should be maximum 5 to 10 degrees. If I exceeded 10 degrees, so there will be a problem when doing unicondylar knee placement. If I have to have a unicondylar knee placement, I have to have a stock total knee replacement with me. I can do unicondylar knee per se, and I don't have in the same time total knee prosthesis with me, because intraoperatively I can change my decision and I go directly to total knee replacement. So I have to have a stock total knee replacement with me. I think unicondylar knee prosthesis is a very good option in some patients if I do a proper patient selection.
What about an ACL deficiency?
An ACL deficiency, it's not preferred. It's not preferred. Although there is a controversy now that we can do unicondylar knee replacement in ACL deficiency, but usually in ACL deficiency, I go forward to total knee replacement. the problem with the high tibial osteotomy, it makes a improvement in the symptoms, but it doesn't attack the pathology. The pathology is still exists. Okay, any further questions? I don't see any other questions. Finally, I would like to thank from the bottom of my heart all our professors, Professor Santosh from India, Professor Elganainy from Egypt, and my dear friend, Professor Cernives, and my dear attendees. Thank you so much for being with us in this very fruitful session, and see you, inshallah, on the next session in next Friday. Thank you so much, sir. Have a nice time. Thank you so much.
Thank you.
Bye.
Thank you. Bye-bye.
Thank you. Thank you. Bye-bye.
Thank you.